Hi, everyone. Welcome to the short webinar on harm reduction services. My name is Jenna Haywood, and I'm joined by my colleague, Savannah O'Neill. We work with the National Harm Reduction Coalition, and this is the second webinar in a three-part series. If you haven't checked out the first one, it's Foundations of Harm Reduction, and today we're going to be expanding on that to talk about what some of, specifically, what harm reduction services look like. So really quickly, a recap on our organization. We're a national capacity building and advocacy organization. We do a number of different things, starting with policy and advocacy at the national, state, and local levels. We offer training and technical assistance, like this webinar. We do overdose prevention. We have the largest Naloxone distribution program in the country called the DOPE Project. We host national and regional conferences, including the world's largest harm reduction conference, as well as a number of statewide and local convenings and conferences and gatherings. And we publish and promote resources and publications that you can find on our website at harmreduction.org. So in our last webinar, we really focused on defining harm reduction and reviewing the principles. So as a quick recap, here is some key definitions of harm reduction. So harm reduction is about incorporating a spectrum of strategies, including safer techniques, managed use, and abstinence. So we really think of it as a buffet of options that really meets people where they are, but doesn't leave them there. And so we're gonna really talk today about what some of those services are that might help people use drugs more safely, and some of the tools that providers can offer to help people meet their goals around what their substance use might look like. But harm reduction is also a framework for understanding structural inequalities like poverty, racism, and homophobia. And so we really want to get across the point, and this is also reviewed in our last webinar, that drugs themselves can be dangerous and do have harms and risks associated with them, but that oftentimes it's the structural inequalities like someone's economic status, racism and access to care, homophobia, the environment that someone lives in that adds and makes more complex the harms associated with using drugs. These are the 6 principles of harm reduction. They're health and dignity, participant-centered services, participant involvement, participant autonomy, sociocultural factors, and pragmatism and realism. So I'm not going to go through each one today, but please do review the previous webinar. And one thing to point out is that 3 out of 6 of these have participant as the first word. And so really when thinking about practicing harm reduction and practicing the principles of harm reduction, it really does center around the needs, the autonomy, and the involvement of the people who are serving, the participants. So just keeping that in mind as we move through today's topic of services.
So today we're going to look at a huge variety of services that exist and are rooted in harm reduction principles. This isn't an exhaustive list by any means. There's constantly new services being added that reduce the harms of drug use, as well as other harm reduction services to reduce risk factors. But these are sort of the core harm reduction services that we look at, that many people think of when they think of harm reduction. And we're going to go into these all in detail. So the first and kind of core service that people think about when you hear harm reduction is syringe access. Sometimes it's almost synonymous with the term harm reduction. And syringe access is really based on public health evidence and decades of it that sterile syringes and using a new syringe each time prevent bloodborne infections like HIV, hepatitis C, and also prevent soft tissue infections like abscesses, endocarditis, probably many things that are seen in hospitals and like the settings you see, really the like negative impacts of drug-related harms on someone's physical body. And syringe access in the United States has existed since the 1980s, really founded for and by people who inject drugs, who were witnessing their community be really negatively impacted by bloodborne infections. And we've seen that now syringe access is the single most evidence-based intervention to prevent HIV transmission. So really, as HIV continues to be high among other groups of people, other populations, HIV transmission in the US around injection drug use is relatively low, and it is lower in communities where syringe access is readily available. In communities where there are not access to sterile syringes, we see spikes in HIV transmission, as well as just overall higher rates. And that's sort of the basis and core of what the evidence says about syringe access, but we know it also really improves other parts of people's health. So even if someone doesn't have a share syringes, which is often what, right, we see as the transmission of Hep C or HIV between two people who are sharing a syringe, if people are reusing their own syringes, it can damage veins and cause other infections based on the way people are having to engage in their substance use. So really, syringe access is a core part of really improving people's overall health, regardless of their drug use, and allowing people to have their health when they potentially stop using drugs or continue to use drugs and not be negatively impacted in those health concerns. And this model can exist a few different ways. So syringe service programs do syringe access, but they also do a lot of other things. So you can see this table is a program in Fremont, California, and they're providing a lot of safer drug use education, referrals, and we're going to talk more about that. And they're doing this in a fixed site location, which is similar to what this person is doing in San Francisco. They're setting up all their supplies on a table inside a drop-in. So you imagine you're walking down the street, there's a storefront or a drop-in center in an office building where someone can come inside, access sterile syringes, access safer drug use information, access referrals to treatment, HIV testing, and access biohazard containers and dispose of used syringes. So that's inside a building. It's potentially the same time every week, and open for many hours. That's what a lot of programs look like. Programs can also look like mobile services. So you can see here, this is set up outside. This is in Oakland, California. There's a table with syringes and of all the other materials, places for people to drop off. And this could potentially move around. So let's say they're here on this street corner near this potential encampment from 6 to 8 p.m. on Thursday nights. And then they are also in collaboration with a library on Sunday afternoons. And so this is mobile services that allow syringe access more broadly distributed in the community. Then outreach, so going actually to where people are living or staying, and this could be outside or going into shelters or hotels or mobile home deliveries to bring people supplies where they are. And so actually doing all the same services but out on the street. Then we have syringe disposal. So you can see part of syringe access is often syringe disposal. It's a part of the programs, but there's also other mechanisms to do syringe disposal. So there's kiosks like these where people can drop off their used syringes. Some states make it easier to dispose of syringes than others. Some states, you can dispose of your medical syringes or syringes for drug use in kiosks. You can mail them back. You can drop them off at your physician, and some states make it more challenging. So we see this as a really essential part of harm reduction to ensure syringes are properly disposed of and not available for people to contract infections or share syringes. And it's a separate strategy from syringe access, but they often exist together. And so then we have naloxone. So naloxone, or as some of y'all probably have heard it, Narcan, is an opiate antagonist. And so it is something that can effectively reverse potentially fatal opioid overdoses. So the way it works in your brain, which if any of you all are physicians, you probably could describe this better than me, or working in a hospital. But the way I describe it to people is you have opioid receptors in your brain. And what happens when you're overdosing is you have so much of a drug that it overwhelms your receptors and your breathing slows and you stop breathing. And then naloxone comes in there and binds to your receptor in your brain stronger than an opiate does and kicks them all off. So it allows you to start breathing again. All those drugs are still in your body, but your brain can't access them. So naloxone is an incredibly effective intervention for when someone's in a potentially fatal opioid overdose. And it's distributed in many different ways. There's been a lot of advocacy in the last 5 or 6 years to make naloxone more accessible. So it depends on your state regulation, but it can be a prescription drug. It can also be distributed under a physician's standing order or at a pharmacy with or without prescription. And really what we see as effective nationwide is getting into the hands of people who use drugs. So why is that? It's essential that first responders and other people have it, but we know that, right, like someone who's using drugs, who's most likely to find them when they're overdosing? Someone else who uses drugs, their friend, their family member. And that's what makes naloxone effective, is actually saturating it into a community so that you have it if you witness a potentially fatal overdose. So that's the model we really like to encourage, is that people distribute naloxone to people at risk for overdose, ensure people have it whenever they're using drugs. And this is something that has existed in syringe access programs since the 1990s. It was really one of the only places for a long time you could get low barrier naloxone access, where you could just walk up, maybe fill out, a 2 to 10 minute questionnaire and have access to the medication. And now we've seen a proliferation of programs who are distributing this medication, from drug treatment programs to jails who ensure people have it upon release because there's such a high risk of overdose, to hospital sites doing it really just out of their emergency department, so that when someone comes in for an overdose, they actually can leave with naloxone and not end up back in the emergency department. So we're seeing it integrated in a whole bunch of creative ways, and it's an incredibly life-saving strategy.
So the next harm reduction service is one that many of you may already be familiar with, known as medication for opioid use disorder, or sometimes called medication for addiction treatment, medication assisted treatment, MAT. So it has different names, but this is, but we use the term medication for opioid use disorder because the medications that we're referring to are only used to treat opioid use disorder and not other substance use disorders. And so this is buprenorphine, methadone, and Vivitrol. Each state has some different regulations around this, but we have seen overall a lot of expansion and buy-in federally and at the state level for medication for opioid use disorder, and we encourage a low barrier form of this, which is also something that and the important thing to remember about medication for opioid use disorder is it's really proven to reduce rates of overdose. So having this available, it can be incorporated with the other services that Savannah mentioned. So there are syringe services programs that will offer medication for opioid use disorder. There are street medicine providers who go out and do outreach and connect people to it, or actually can get them on it right there on the spot. So there's been a lot of movement around making this easier to access, reducing barriers, and really just trying to make it as easy as possible for people to access it, and if they don't stay on it, to be able to re-enter services seamlessly. The next is supervised consumption services, and these currently there are no legally mandated supervised consumption services in the United States, but there are hundreds of them around the country. And what they are places where people can bring a pre-obtained substance and consume it on the property. So they've sometimes been called supervised injection facilities, but the term supervised consumption services has been adopted to incorporate other kinds of a consumption that might not be injection. And they can look a lot of different ways. This is one example where you can see there's sterile stations set up that have biohazard containers, so that people can reduce risk of injecting outdoors, reduce risk of consuming drugs in a place that might be unsafe, or if they're at higher risk for overdose or higher risk for law enforcement interaction. And really, just like syringe services programs, these are points of access into other kinds of care. And so that is one of the highlights of them, is that they are places where people can get access to wound care, where they can get referrals into treatment if that's a goal they have, where they can get therapy or housing placement services. And what we know is that an overdose death has never occurred in one of these sites. So they really are effective at reducing overdose death, because someone is on site to be able to administer naloxone or provide other medical care if somebody overdoses. Low threshold drop-in centers. So these also can be incorporated with a lot of other services. Sometimes fixed syringe services sites have drop-in centers attached to them. Sometimes clinics that offer medication for opioid use disorder have drop-in centers attached to them. But drop-in centers can also be a harm reduction service all by themselves. You can see in this photo, there's a couch and a TV for people to come in outside of the elements and rest, to use the internet, to use the restroom, to make copies, or a computer, to use a computer, to do laundry. So there's all kinds of things that a low threshold drop-in center can provide. And the low threshold part really means that it's incorporating the principle of meeting people where they're at, and not that there aren't agreements or rules around how people might should be expected to treat each other in the space, how people might be expected to treat the space, but that there aren't requirements around sobriety in order to access the services. Housing first placement services, along the same lines, is the idea that housing should be addressed first before looking at other behavior that like substance use, so that somebody could receive housing without having to have a negative urine tox screen, that they could receive housing despite other factors that might be going on in their life. And pharmacy access. So pharmacy access is a point of access for sometimes for syringes, depending on what the rules and regulations are in the state you're in, and also sometimes for naloxone as well. And they can also be sites for syringe disposal, depending again on the community. And one of the ways that advocates have tried to, I think one of the important conversations to have around pharmacy access is also the piece of the education that can be done in a local community around talking to pharmacists about what kind of services they offer, how they're interacting with people who use drugs in the community or people who are at risk of overdose, and what their role is in helping to reduce drug-related harms in their community. And so I think that there's been some places that have made a lot of progress in this, but unfortunately, a lot of people still experience a lot of stigma with pharmacy access. And so, looking at education for pharmacies in your community is something to consider for a service as well. And all throughout this conversation, we've talked about referrals. Referrals are really such an important service that can be incorporated into any one of these interventions that we named, or just a standalone service that could be provided at any kind of clinic or hospital, any place where you're going to be working with people who are in need of other services. And so we briefly covered the principles, but I've mentioned that other webinar a few times, and we really go deeper into that. And, you know, it's important to remember that it's really not just these tools and services by themselves. So it's not just providing Naloxone or providing syringes or other sterile injection equipment or providing medication for opioid use disorder, but it's also doing that with the principles of harm reduction, you know, doing that rooted in the principles of harm reduction, you know, treating people with dignity and respect, centering the services around their needs, thinking about the autonomy of people you're serving, considering the socioeconomic factors that contribute to everything about somebody's life and the way they're showing up to receive care. And so even if you're not able right away to start some of these services that we mentioned, you can still ground the way you interact with people in the principles of harm reduction and be practicing harm reduction. And likewise, you could be providing all kinds of tools and not be considering the principles of harm reduction and not really be practicing harm reduction in that way. So we'll leave you with a few questions to think about. And one is, how have you already been practicing harm reduction at your hospital? What are the principles that come easiest to you, and what are the ones that you feel challenged by? What are some of the services you could imagine incorporating into your hospital setting? And which ones do you feel like might be a long way off, but you could start having conversations with your colleagues about, or doing research to see what else is already in your community? And so, yeah, what would expanding harm reduction look like in your hospital? So what do you know about Naloxone access in your community? Do you know if there's any drop-in centers around? Do you know where you can refer people to if they're looking for housing? Do you know where you can refer people to if they're in need of safe injection equipment? And working on building relationships with those other communities and with the networks that are already in place where you live. When we talk about referrals are really most successful when you can do a warm handoff, when there's already a relationship built with the other provider, so that you know when you're sending somebody over to a housing placement person, that person is going to treat them well when they get there, and that person is going to understand all of the different factors going on in the life of the client before providing them services. So these are just a few questions to think about, and we'll be doing another webinar that takes a deeper look into how you can implement some of this stuff into your hospital. Anything in closing from you, Savannah?
No, thanks so much for participating. And like Jenna said, we're really going to get into the action steps you can take to integrate the things we've talked about into your hospital. So hope you join us for the next webinar.